So, when you get to the level of Professor Schilling and you can just look at an ECG and immediately know what it shows, you don't need to formally report an ECG. But even if you're at the intermediate level, and some people are at quite a high level in here, I would still recommend that when you're in the thick of it, you formally report an ECG, because it's really easy to pick up some of the problems and not all of the problems on an ECG and make a mistake as a result. So I would suggest a very simple pattern here that you may have been taught some variant of when you're at medical school. You start off with the rate. Right. And you start, a normal rate will be between 60 and 100 beats a minute by convention. So that does not mean that if you've got a heart rate of 55, you've got some disease. Does anybody here do cycling or running or swimming to a high level? Chap at the back, what's your resting heart rate?
52.
52. So you haven't got a disease even though your heart rate is abnormal. It's, well, we hope not. It's reflective of high vagal tone caused by high levels of physical fitness. So the fitter you are, the higher your vagal tone. The vagus nerve slows down the sinus rate. That is normal. So you're probably all too young to know who Miguel Indurain is, but these cyclists who win the Tour de France, their resting heart rates are of the order of 32 beats a minute. But when they exercise, they go right up to 200 beats a minute, and they have the most incredible change in cardiac output to supply the skeletal muscle. And that's a healthy heart. So 60 to 100 beats a minute. You then look at the rhythm, and broadly, you want to define your rhythm into 3 categories when you look at the rhythm strip. So typically, the ECG computer will put lead 2 down onto the rhythm strip. And the reason for that is it's one of the best leads for seeing P waves. So V1 and lead 2, very good for seeing P waves. That's why the ECG computer defaults to that as the rhythm strip. So your purpose of using that is to identify, is it sinus rhythm? Is there one P wave to one QRS in a one-to-one predictable fashion? There's no extra P waves, there's no variation in the rate, there's no variation in the relationship. Sinus rhythm's the first one you want to identify. The next one is AF. If there's AF on the ECG, I want you to recognize it immediately. So there was a study some years ago of the ability of doctors coming out of medical school to identify atrial fibrillation, and it was really quite low. It's of the order of 60%. So AF is irregularly irregular. Now, we're going to have some more stuff on that this afternoon. But if you have an irregular baseline with no clear, predictable, discernible P wave activity, and by that I mean if we cut the ECG in half and asked you to draw where the P waves were, there's no chance you get it right in AF. Okay? There might be some stuff that looks like P waves in AF, but if I ask you to draw where they're going to come, you're never going to get it right. Okay? And atrial fibrillation is very important because it's responsible for 1 in 4 of all strokes, and they tend to be big strokes. It's very easy to treat and reduce this risk with anticoagulation. And then the final one is, have you got any emergency rhythm? So broad complex tachycardia. You're going to immediately look and establish whether you need to instigate emergency management. Broad, fast, regular rhythms. Think ventricular tachycardia, which is dangerous. It's an emergency rhythm that needs emergency management. Now, cardiac access. So hands up who's confident that they can establish what the cardiac access is on an ECG. It's all right, you can be bold. There's 1 there. 2, excellent. 3, okay. So the methods taught for establishing a cardiac access are orthodox. And so a lot of medical schools will teach a moderately complex algorithm that people rapidly forget, particularly because there are 5, 6, 7, 8 different ways taught. So you get out of medical school and you've got moderate confidence, and then somebody teaches you a different way and you can't remember. So I'm going to teach you in a moment a simple way that gets most of it right. And we've taught over 2,000 doctors now, and not a single one of them leaves the room unable to get 98, 99% of people's cardiac access right within about 3 seconds of looking at the ECG. So I'll show you that in a minute. It is a very limited